So in the next 15 minutes, I'll talk about the concept of flow remodeling and then the vascular treatment of cerebral aneurysms. And I think we should have a different look to aneurysm occlusion if we watch all these discussions. So one of the most important parts of the revolutionary change in aneurysm treated by flow diverters has been making a treatment possible for aneurysms, especially in bifurcation, especially in the locations that some side branches are coming out of the aneurysm site. So we had to describe a new aneurysm occlusion process called flow remodeling. So in the early experience of flow diverters, like in mid-basilar fenestration, when we take one arm of the fenestration and place a flow diverter, we realize that actually, surprisingly, the flow demand just makes a different healing reaction in the vessel and creates a new vessel. So we've been seeing this was happening with the flow demand of that structure. So especially for such aneurysms like anterior choroidal coming off the aneurysm sac, and there are two different aneurysms with anterior choroidal coming off the aneurysm sac. When we deploy a flow diverter across the aneurysm neck, it depends on the flow demand of the artery. It usually, aneurysms shows reverse remodeling, usually completed with excellent reconstruction, with important vessel patency, and this was a revolutionary advancement. So this happens sometimes at 6 months, but sometimes with 2.5 years, with some additional placement of flow diverters. But usually the concept works out. So this is a pike aneurysm, typical surgical case of years ago, but now we can actually modify the flow at the base of the aneurysm and keep the patency of the pica flow with occlusion of the aneurysm. So this just gives an unbearable simplicity, and that process of flow remodeling is not always completed with perfect reconstruction. And it just creates a lot of misinterpretation. But remodeling of the aneurysm sac may end up with stable remnant that become continuation of the vessel with flow demand, like in this trifurcation aneurysm in the right MCA, and the most superior trunk was pipelined, and this is the 6 months follow-up, and this is the 18-month follow-up. So the question is this an aneurysm remnant? Do we still have to call this as an aneurysm remnant? I don't think so, so we'll give the answer. So if the flow demand of particular vessel is not stronger exists, like in this distal ICA bifurcation, dissecting and ruptured aneurysm treated not in acute phase, there is obviously no flow demand in the right anterior cerebral artery because it fills from the left side. So when we place a flow diverter from ICA to M1, then we create a new bifurcation with an asymptomatic occlusion of the right A1 due to flow demand of that particular vessel. So this was a case treated with very first generation of silk stent back in 2007 with that unruptured pica aneurysm. So we think that, oh, we did a great job. Okay, it's a good result because we only knew that at that time that aneurysm should be treated in that particular vessel that its neck is originated. So it was a good result. However, if I treat this aneurysm today, I would definitely do this. Place a flow diverter across the pica origin. Depending on the size of the pica, you can just, with the experience, you can go with the 1 or 2, sometimes 3 flow diverter, just to drop its diastolic flow so the aneurysm can remodel. So we do that, actually. We do that confidentially. We do that, I mean, we trust the treatment, and we do that, we do believe that. So this is the right A1 aneurysm, and this was treated by, this was again ruptured, but not in acute phase. This was treated with just changing the flow at the origin of the anterior cerebral artery, A1 portion, placing a flow diverter from ICA to M1, and there is no flow demand in this particular artery because it was filling from the other side, and then 3-month CTA, 6 months angiography, and 18-month control shows us a class 1C occlusion. So it means that aneurysm is occluded, also dependent vessel is occluded asymptomatically. So it's just the matter of the concept in your mind. So this was a ruptured ICA aneurysm, that ICA comes off the neck. We tried to, this was a ruptured case, and so we tried to get in that aneurysm. It was not possible. So we just treated the aneurysm with a couple of flow diverters from an advance, from the parent artery, with just changing the flow in the anterior inferior cerebral artery. So this is the 1-year control with a class 1A occlusion that showing that full patency of the anterior inferior cerebral artery and aneurysm occlusion. So this is a different concept. Sometimes that concept cure very complex aneurysms. This case was done one of my pupils, and this is a case of tough case, right ICA occlusion, and the ICA PCAM aneurysm filled by the right PCAM artery. That right PCAM artery also filling the whole right hemisphere. So with the concept of intrasaccular or reconstruction in the neck of the aneurysm thing, and he tried, obviously it was not easy. So he come from the basilar and made a loop, tried to go from the aneurysm. He achieved that, but it was not possible to deploy a flow diverter or stand stably in here. So even if it is possible, it was not easy. So then he just thought that what he learned from me, and he just deployed a flow diverter, couple of flow diverter, in front of the right PCAM artery at its origin, from P1 to P2. So just drop the flow from an advance. This is immediately after the aneurysm stagnated. And you see, this is before treatment from left carotid injection. This is after treatment. So the demand is changed. So basically the A1 is feeling better for cross flow. And look what happened at 1 year. The aneurysm is gone and the A1 got thicker. So basically just the concept treats the patient here. Not dealing with you don't have to deal with the very difficult maneuvers and difficult standings and to show up things. So the secondary the flow remodeling effect of these treatments, we've been observing different follow-up angiographic results. So that's why we come up with the SAICI, we come up with a new aneurysm classification system because of the impact of flow modification. We have to talk each other with good system, not like adequate or inadequate occlusion. I really hate that terms, the adequate and inadequate or whatever, things. So basically we have the same Raymond-Roy classification, we just update it according to the new need. So we have the class 1 complete occlusion in 3 groups, depending on the vessel's patency, full patency, reduced caliber, or asymptomatic occlusion. Class 2 is same, class 3 is same, class 4 is just for postoperative stagnation, and class 5 is important. We call it stable flow remodeling at the base of the aneurysm that we should no longer call as an aneurysm remnant or treatment failure. So this is very important. So I'm going to explain in same group aneurysm. This is a distal anterior cerebral artery aneurysm that callosum marginal is just coming off. This is Fred Jr. and class 1A occlusion. Aneurysm is gone and dependent vessel is in full patency. So pericallosal is coming off the sac this time. The stent was placed from A2 to callosum marginal. The flow demand was not that high in that particular pericallosal artery, so the aneurysm is gone, but the vessel, dependent vessel, which is pericallosal artery, got reduced in caliber, so this is class 1B. Or this was a ruptured aneurysm and not treated in acute phase. Again, pericallosal is the integrated branch. At 6 months, it is asymptomatically occluded, feeling retrogradely, class 1C, but sometimes it shows an interval change. It did in this case. At 18 months, it started to refill antegrately, and with class 1B occlusion, because it's reduced in caliber. So sometimes this doesn't end with perfect reconstruction. This was a wide neck right fusiform wide neck right M1 aneurysm with a large temporal artery is coming off the aneurysm sac. So basically the pipeline is placed, as you see, at the neck, and this is a 1-year follow-up. See, aneurysm showed already some progressive reverse remodeling, and it just continues as a continuation of the vessel with a large flow demand, which is the right temporal artery. So 2 years follow-up, this is now we can call class 5 stable flow remodeling in the long run. As you see, we should not call this anymore as aneurysm remnant. So this misinterpretation especially happened in the posterior communicating arterial aneurysms with embryonic peak comes off the aneurysm sac. So this misinterpretation led that some papers concluding that there is no indication of flow diversion in this setting. It's just not matter of flow diversion. It matters how much flow diverter are going to use there. So for large flow demanding embryonic peak in the ICA, it should be at least 3 pipelines. And this is 3 years follow-up, and this is 10 years follow-up. And as you see how there is such a reverse remodeling, so basically the PCOM becomes, the aneurysm sac becomes the continuation of the aneurysm sac. So this is something that we have to develop in our conceptually in our mind, that, and especially for PCOM aneurysm, so that misinterpretation is leading in the wrong places. So this is another large embryonic PCOM aneurysm, 3 pipelines, and 6 months follow-up. And don't expect to have a perfect reconstructive response here. The matter is if this aneurysm is going to bleed in long run or not. I never seen in the last 15 years. And this is 6 months follow-up, and this is 5 years follow-up, exactly same in the MR angio. This is the class 5 stable flow remodeling. So that experience built up and let us treat complex cases with unbearable simplicity. But of course, if we do the proper management pharmacologically, technically, and conceptually. So there was a question, so what we should do in bifurcation? So what we should do to give the time, especially with pipeline, we at least do use 0.5 millimeter oversizing according to the proximal vessel size. I just heard somebody ask to René Chapeau, okay? So we do oversize because most of these aneurysms are in convexity. So you increase decrease the mesh density a little bit to give a time to aneurysm to remodel, that vessel become the continuation of the aneurysm sac. So the importance of especially MCA bifurcation is the chrome cobalt's geometrical modification effect. So the geometrical modification effect is so important for such aneurysms to have such flow remodeling, and again with nice class 1A occlusion in the wrong run with full patency of the vessel and occlusion of the aneurysm. So this technique, I'm very happy that some of my good friends and non-believers become believers to this technique. And this is a patient I got from Ishlak, my good friend. And look at the aneurysm. And very tough one. It's a multi-segment disease starting from bifurcation to extending into the superior trunk. All he gets to do is just to find the inferior trunk and place the pipeline. And look at this. At 1 year, this is class 1B occlusion with perfect reconstruction. If there is no flow demand, then that vessel may not be needed by the brain, as it happens in this MCA aneurysm with a superior trunk is dependent vessel. This is pre-op, this is 6 months, class 2, and this is 1 year follow-up. The vessel is gone, it feels retrogradely, not anterogradely, and aneurysm is gone too. So this is class 1C. But again, in some patients, you see in the follow-up, like in this left MCA with large inferior trunk integrated, you do DSA, and please don't jump on this. Hey, this is aneurysm remnant. This is not treatment success. We discussed this in some other meeting with a surgeon today. So they're asking for a complete treatment. I mean, what is complete treatment? The complete, we are chasing after a geometrical, perfect, artistic picture showing everything is gone. And you do the 3D, you realize that these aneurysms show a beautiful flow remodeling with such a simple treatment without just jerking around from the aneurysm and make a loop. I like to do this. I mean, most of this technique, you guys know, invented by me. I mean, we proposed the intra-aneurysmal loop technique and with a balloon, and we described that. I love doing it, but I very rarely doing it now because, I mean, the engineering bring this simplicity, so we gotta use it. Look at this aneurysm. Dissecting M1, trifurcation, very complex. The flow geometrical modification effect of the pipeline is needed here. This is 1 year follow-up. Is this a treatment failure? No, this is not a treatment failure. This is just a class 5 stable flow remodeling. This becomes the continuation of that particular branch which is integrated. It helps also the ACOM aneurysms. Look at this, the subcallosal is coming off the aneurysm sac. So our surgical colleagues that they perfectly know that these are the toughest cases because if you close this subcallosal artery, the patient is going to be a plant. If you coil this, when this is occluded, the patient is going to be plant again. So you just deploy a flow diverter. And look at this, 1 month MR angio, 6 month MR angio, aneurysm is gone. And this is a 1 year control DSA showing the perfect aneurysm occlusion with class 1B occlusion that subcallosal become a little bit reduced in caliber. And this was done, one of my fellows again, ACOM aneurysm, right A2 coming off the aneurysm sac. Very simple, left A1, left A2 flow diverter to pipeline, I guess, placement. And before treatment, the A1 right side is hypoplastic, but 6 months later, not anymore. It's just the flow demand rearranged everything in the ACOM complex. The aneurysm is gone, right A1 got bigger, and no longer filling from the left A1. But don't expect these results all the time at 6 months as we used to. This is wrong. This remodeling develops in a longer period of time in MCA bifurcation. You look at the 6 month control, is frustrated, the vessel is gone, aneurysm is filling, bad result, 12 months, vessel came back, aneurysm still filling, bad result, and 18 months. Aneurysm is perfectly gone and we have the new bifurcation. So I cannot emphasize enough that is very, very important to have an intensive and LTA controlled anti-aggregation for such progress, and that anti-aggregation should not be clopidogrel. If you had to use clopidogrel, then do treat this aneurysm either surgically or with some other things. And it develops in a longer time, as I said. Again, another example, 6 months, don't get frustrated. 2 years, perfect class 1B occlusion. And this is the longest I ever seen from Jivan's case again, with a Fred Jr., 3.5 years after treatment. They follow this patient with IV vaso-CTs. Aneurysm got smaller, 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 and finally gone. And this is the 4 years follow-up. So what it matters is just to protecting patient from a bleed, right? I have seen no bleed in the follow-up of these patients in the last, how many years? I don't remember now. It's 12, 13 years. So the long-term follow-up of such cases that with integrated branch, I think this MCA bifurcation has the largest number of serious we did with Sharber's group, and we call actually 98% obliteration in the long run and with very low morbid mortality. with good anti-aggregation. So, however, if we keep calling, for example, this is the case we just did in the WLNC online last year. We discussed, and we decided to place a flow diverter pipeline. We need a geometrical modification. We did change the geometry, and this is just 1 month later. We don't have the 1 year follow-up in this patient because it was just treated in the course. But I'll bet you this flow remodeling is going to continue forever. So if we keep calling this as aneurysm remnant, of course, we don't say that 98% obliteration rate. Another one, 6 months, this patient had a ruptured left MCA. This is right MCA with integrated superior trunk, and 4 years. So I can show you like many of them. It happens for the web. Sorry about that, but we discussed this with many times with Laura and Piero. I hate this adequate or inadequate occlusion thing. I think we should call this class 5 stable flow remodeling. So if 2 or 3 consecutive angiography shows that same remnants, like in this MCA bifurcation, as Professor More showed perfectly, it just simplifies everything. Look at this. Look at the angles of the superior inferior trunk. It is hard to place the flow diverter. It is not easy to do the Y stenting, or it's not easy to do double balloon. I love doing it. I can do it if I deal with like 8 hours, but just deploy a nicely sized web and don't expect perfect anatomical result. This is 9 months control, and this is 18-month CTA. So this is class 5 stable flow remodeling. So guys, we gotta change our look to aneurysm occlusion. So the matter is, if we protect the patient from a bleed or not. So I hope we continue this in Shanghai face-to-face, because I'm tired of these Zoom meetings. Thank you very much.